49 in your book is a good summary of the medication. And like we said, remember that just slows the progression. We went over the stages. They're on page 439. A couple of things that I wanted to hit on a little bit more was delusion, hallucination, and illusions. Sounds real simple to you. Delusions are fixed and they can't be altered. Delusions of grandeur. How we talked about when people are on that manic phase of the bipolar disorder and they're feeling really good about themselves, they may have delusions of grandeur. Those are a fixed thought that a patient has, and you're not going to change that. Okay. Hallucinations are different in that they are false sensory perceptions without any real stimulus. You're seeing things, you're hearing things, and there's nothing in reality to make you have them. That's a hallucination. Yeah, sensory perceptions. And then illusions, an illusion is a misperception of something that you really see or hear. Like you wake up in the middle of the night and you're kind of confused and you see a limb moving around outside your window and you have an illusion that it's somebody like trying to look in your window or something. Yeah. Something weird, something happened that night. I thought the dog's barking and I went to the door and I could have swear I saw my husband coming across the yard looking at the mail. It was around 7 and it was dark and I went over the door and he wasn't there and I was like, oh, I shouldn't be telling you. So we've got this teacher and she kind of does all the things
that she taught us about.
Everything that came up, but you just got to understand. So, again, make sure you're looking at the table to understand the difference between delirium, depression, and dementia. And make sure you go over your meds. Your meds, medications. And then mood disorders. Again, I covered most of the table. But we just did mood. And with depression, one thing we didn't talk about were the phases of depression. If you look, a good summary is on page 69 in your book. I think I touched on it. But acute phase, severe clinical findings of depression. Treatment is generally 6 to 12 weeks. And remember, we said they may need to be in the hospital during this phase, maybe not the whole time, but this may be a reason why someone ends up in the hospital. And we said they were at risk for what? What do you need to really assess with them? Suicide risk. And your main goal here is to reduce these symptoms, reduce the symptoms of the depression. And bless you. And now suicide, if you've got somebody on suicide precautions, and the policy is they're one-on-one observation, does that mean you sit at the nurse's station and you can kind of see their room around the corner?
No, that means you sit there with them, correct?
That means one-on-one, within arm's reach. So always remember that is what that means. We were talking about nurse-patient ratio, like in the hospital and the mental health unit. The big difference we talked about in Unit 1 was the difference between an outpatient or something. When you go to the hospital, you have observation around the clock. Most mental health units, you have to lay eyes on every patient every 15 minutes. So you're documenting. And so the techs and the nurses work together. Sometimes they use LPNs work together to make sure that everybody is seeing everybody every 15 minutes. But even then, if they're on suicide precautions, then they need to be within arm's reach and you watch them constantly. If you have to go do something, somebody comes and relieves you and watches them. They don't have things like no shoestrings, no plastic bags. You don't want your badge around your neck in those, units, just a lot of safety precautions. Then the continuation phase of depression, they're improving their ability to function. Treatment here, this is after the acute phase, this treatment usually lasts 4 to 9 months. And you're still doing a lot of education. You're trying to keep them from relapsing. And medication management. Is this current regimen of medications working? Psychotherapy. So therapy, med management, education, all working to keep them from relapsing. And then maintenance phase. This is remission of their symptoms. This is where they're not having the major depressive symptoms anymore. It could last for years. And your goal was to keep them from having another major depressive event. So, there's your goals of care, this monitoring, I already talked about that for suicide risk. Helping with self-care, especially during the acute phase. If they're so depressed that they've ended up in the hospital, this may be the patient that you have to go get and walk them down to the day room. They're not to the point where they're just going to come down and go by themselves. You may need to help them with their ADLs. Let me help you get up and let's wash your face and all. Maybe put on some clothes and change. And let me help you. You have to make time to be with them. They may not even talk at this point. They may not be able to talk much at this point, but you're like, I'm going to come sit with you for 15 minutes today after we finish group. Maintain that relationship of trust. Be there when you say you're going to be there, and just sit with them as they're working through this. You may want to make observations. You don't want to increase their anxiety, so you don't want to say things like, you were supposed to be down there at breakfast today, but you weren't there. It might be better to say, I noticed you weren't at breakfast today, and let them talk to you instead of causing anxiety. Those communication skills. Don't rush to fill empty air. I'm real guilty of that. Sometimes when you're talking or you're talking with the patient, you feel like you need to kind of fill the empty space. They're in a major depressive disorder. They're having trouble with their emotions and all. Give them time to answer. So sometimes just sit tight and wait. Give them time. Don't want to make them feel pressured. Really about it with depression. Again, electroconvulsive therapy, ECT, is used a lot with depression. The only time I've really ever seen it used was with depression, major depressive disorder. A lot of times, like with a patient who's catatonic, so depressed they're just hardly able to even communicate at all. And those are real good clients for electroshock therapy. So go back over everything that we went over on that. Okay, children. So this will be a real high-level look at adolescent mental disorders. Well, all of this. We could really spend a lot more time on everything than what we are. But 1 in 5 children and adolescents in the United States has a major mental illness. And 2/3 of all young people with mental health problems are not getting treatment. So 2/3 are not getting treatment. what are some of the things that puts kids at risk? A parent who has a mental disorder, history of abuse, neglect, and they witness violence. So what are some of the causes? Well, of course, some of it's genetic, and some of it is biochemically in brain development. The same things we talked about before, neurotransmitters, brain issues. Also, things that can contribute are temperament. Some children just have a different temperament than others, put them more at risk. Then resilience pops up again. To the children that were abused, you may have a child over here that was abused and neglected. Well, you could have siblings in the same situation of abuse and neglect, witnessing violence, all those things that are risk factors. One sibling may end up with a major mental illness and the other sibling may just be fine. So some of it is resilience. Your ability to bounce back, like we talked about in Unit 1. Some maybe the different genetic makeup of the kids that could even be different. And then there are environmental factors. Your assessment with these patients is the same as with an adult. Use a mental status exam, suicide risk, culture and background. But then one thing, well, you also do it on adults, but real important with children, a developmental assessment. Developmental assessment. Remember in level 2, when we were doing pediatrics, and you did the Denver developmental assessment? Or when you were in newborn nursery and you did the Dubowitz? And that's to see, is the child developmentally where their age is? Okay. Is this 2-year-old developmentally acting like a 2-year-old, or are they delayed? Because you don't want to be assessing a child for mental illness and you're seeing things in their behavior that you think is mental illness, and really come to find out the child just is developmentally not where they need to be. So you need to know a developmental assessment. At what level does this child perform on? Are they on track developmentally? Because here's the other thing, if they've had abuse and neglect to the point, or you think there's some mental illness, you need to see if they're developmentally intact. Because what can that do? That can throw them off developmentally. If they're having some really awful things happen to them, then you also need to see, does it affect them developmentally? Do you have a 5-year-old that doesn't have the speech, the level of speech that they should? How can they talk to you? Do you have a 2-year-old that can not walk or something? So development. General interventions include family therapy, group therapy. Basically all the things we've already talked about with kids, but we'll hit on a few different things that are unique with children. You still got to manage the milieu. If you're having a family group therapy and the 15-year-old is abusive to some other people in the group and they can't control their actions, then you need to do like we talked about with the adults. Take a break maybe and ask them to have this 15-year-old step out because they're disrupting the group dynamic. Manage their behavior so that you can manage the group or manage the milieu. You can use seclusion and restraints with children. The last time I looked at the list of deaths in the country from restraints, a lot of them were kids. And a lot of them were physically holding restraints, you know, like in a adolescent group home or something, instead of putting them like in 4 points or something, they were doing physical holding, and the child suffocated or something. So you can use all sorts of restraints on children. All the same safety guidelines apply. They actually, when we were on our rotation last semester, they had to do a takedown and restraint from like a 13-year-old that came in. It was upsetting. You could hear her all over the building, and they eventually had to just physically take her down and medicate her and put her in restraints. And when we left for the day, she was still in restraints. So the same safety guidelines. You use the least restrictive method first. You try everything you can. If they're unsafe, they're going to hurt themselves or others, you go ahead and put them in restraints, call the provider. You also could just try a quiet room or put a child in timeout to manage behavior. You also can do the cognitive behavioral therapy with children with mental illness, but you also might want to use play therapy. Children learn a lot through playing, and so sometimes you can just observe a child playing, or a therapist can play with them and try to work through, and they will talk to you and tell you things when they're playing that they wouldn't tell you otherwise. Bibliotherapy, they could tell a story or write a little story, and that would help you understand what's going on with them. Now, some of the disorders you see in children: attention deficit hyperactivity disorder, ADHD, oppositional defiant and conduct disorder, and ADD. So when you're assessing these clients, you want to observe or assess for the relationship between them and their parents or their caregivers. And again, their developmental competencies. Are they developmentally where they need to be for their age? Then you're assessing for ADHD, you're watching their attention span, their talkativeness, their activity level. Just what are they doing? These clients are real at risk for hurting themselves or others. So a nursing care plan would be risk for self-directed or violence to other people. You can't, if you're with them in group or managing the milieu, say in an adolescent home, you can't let them be like lashing out and hitting another child. So if there's violent behavior, you just like with the adult, you separate them from the group. Impaired social interaction, part of your goals as a nurse and for the interdisciplinary team is to work on their social interaction skills. Just like with the adult, you're trying to build them a skill set so when they go out, they can function socially at the highest level possible for them. Your main goals are to keep them safe. If they're running around and doing something that they're at risk for falling or hurting themselves or hurting somebody else, you have to stop them. And they need to learn effective coping skills and learn how to build friendships. part of the behavioral therapy with ADD, ADHD is rewarding good behavior and working out like a behavioral contract with patients where they agree to behave within the safe bounds that y'all have come to an agreement on. You're trying to change the behavior that's negative, so you reward positive behavior. And a lot of it is teaching the parents these skills. On the PowerPoint, there's a question that says, which statement demonstrates that a parent understands the diagnosis of attention deficit hyperactivity disorder? And the first one is, my child will never be able to graduate or go to college, but may be able to learn a vocational skill.
Wrong.
My child's performance will improve in a structured setting that provides rewards for appropriate behaviors. That's it. Nothing is wrong with my child. The school hasn't provided qualified teachers in classroom settings.
Denial.
Denial. My child is just going through a stage. This problem will go away with him. And that's you as an RN being able to explain the difference between stages on their development. And no, we're not talking about this type of behavior is not in a normal stage of development at all, so this is different. Now, if it's a toddler acting out, there are some acting out that toddlers do in certain stages, but there's a difference between developmental not meeting a developmental milestone and having ADHD. It's a set of behaviors that are different. For now, that really pretty much covers everything on that syllabus. Let me double check. There are some meds in this part of the unit that are new to us. Pull that up. You have your stimulants, which is something we haven't gone over yet. And it's a paradoxical relationship between hyperactive behavior and you're given a stimulant. But it works together to help them perform better. Let me pull up the 25. Yeah, so you got your stimulant group for ADHD, but also in here is the SSRIs, tricyclics, and SNRIs.
Hi. Huh? I don't know.
So, I'm not going to go over much else. I'm going to go ahead and let us start this activity and then finish up with the content for now. And then we'll do some more wrap up on it all tomorrow. But let's go ahead and do the hearing voices and y'all can just study and I'll put together. Now the questions that we put together for y'all in ATI in Unit 2 cover just these topics, and there are a lot, the different meds are in there too. So if you're taking it, that should be helpful. But really for today, that's enough, and I'm just going to let y'all work on all this. wrap it up, and then we'll do personality disorders. We're doing it on time. And the other group won't even back. So I'm gonna go see if the room is already.